So maybe we'll get started. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Training Space. For those who I haven't met and those who are online, my name is Sean Barinholtz. I'm anesthesia and critical care physician at Johns Hopkins. I'm a member here at Pikesville, and I have the honor of serving in the medical director's office, car 609. On behalf of Dr. Pollack and the medical directors, Dr. Sagel, who's here with us, Dr. Wittberg, who's coming as well. On behalf of the EMS office, Director Shedding, Capt Stewart, who undoubtedly is online, Captain Willits, who's with us today. Thanks for coming. Thanks for what you guys do. Thanks for your dedication to lifelong learning. Also a shout out for Ashley and Hunter in the back for running our live stream to give access to people from across the county. Thanks. I think last time we had 22 people online, so it's definitely a growing community, so that's really amazing. I can't read. So tonight we have Matt Goldstein. Matt is a physician assistant with over 20 years of experience in cardiology and emergency medicine. Matt volunteers as a paramedic in Baltimore and coordinates a Maryland statewide public access AED program. I also know he's a lifetime member here at Pikesville. His American Heart Association Training Center, StartBeat LLC, has trained thousands in CPR, first aid, use of the AED, ACLS, and PALS. He holds an adjunct faculty position at Towson University Physician Assistance Program, as well as teaches a healthcare informatics and technology course at Nova Southeastern University Doctorate of Health Sciences program. Matt has been an invited lecturer at the Johns Hopkins University School of Medicine, School of Nursing, American Association of Critical Care Nurses, and American Academy of Physician Assistants, as well as other national groups. He has authored a book on topics in electrophysiology, heart rhythms, and 12-lead EKGs sold on Amazon, as well as authoring several articles on cardiovascular topics in leading peer-reviewed journals. Matt, again, thanks for being with us.
Thank you. Don't believe everything you hear. Anyhow, so last time, clicker. If you don't have a clicker, grab one. So last time we went through a review of the anatomy of the heart. We described how to perform an EKG. We went through some basic topics in electrophysiology as relates to EKG. We talked about rhythms and what would be very important for us to know, especially a BLS provider who's might be doing, putting the person on a 12-lead EKG to transmit it to the hospital, and maybe something bad is on that EKG, and they should be able to pick up on that. So we identified the good, the bad, and the ugly. And then we understood from some cases that we showed why you can't trust the machine, because the machine could be pretty good, but not necessarily always good. So tonight we were supposed to just go through some practice cases, but I think that we'll kind of embellish what we did up until now, because I had some questions afterwards that I think we can kind of fine-tune our EKG skills, and then we'll take it a step further and talk about some of the things that sort of mimic an MI, and then we'll do some practice cases. And when we do the practice cases, we'll use the little clickers, because that way everyone has the opportunity to kind of be where they are in this and make their own decisions instead of one person dominating the conversation. So that's what we'll do. So if you remember, we had this concept of the EKG machine staring at a center core of the person's heart. So we have this heart here, and we had the EKG electrodes on the chest, and we had the limb leads that kind of formed other views. And we said that the whole idea of these is they're looking at the person's heart from different angles. One person who was online last week asked me a question and asked me, well, why is the QRS complex sometimes the R wave's taller than the S wave, and sometimes they're kind of equal, and sometimes there is no S and there's R. And so I told him this answer. If you think about, I think Malcolm Thaler's book, the only EKG book you'll ever need, but that's not true. I think it's Malcolm Thaler's book. Shows an elephant and shows somebody looking at the elephant from the front and looking at the elephant from the back and looking at the elephant from the side. And the whole idea is it's still an elephant. I think about it, if you're looking at a car, if I'm staring at a car and I take a few steps this way, so if I'm right in the middle of the car, I see sort of the car, and I see an equal amount of car to my right and to my left. But if I step over, let's say 4 feet in one direction, I might see more front of the car and less back of the car, and vice versa. And so that's what the whole idea of the EKG, different leads, it's sort of a different view. It's still looking at that car, you're still looking at that same person's heart, but you're from a different angle, and that's why you might have more of a positive QRS complex, more of a negative QRS complex. So really what we're going to do is we're going to think about these chest leads, these precordial leads. They're actually eyeballs on the chest, and they're staring at the center core of the person's heart. And what they're looking at is how electricity goes towards and away from those eyeballs. And then we have AVL, lead 1, 2, 3, and AVF. Those are formed by the limb leads, right? The whole idea of that triangle that the limb leads form. And we also have the augmented leads, sort of cross sections of that triangle. That's what those are looking at when it comes to putting electrodes on somebody. So we talked about coronary artery anatomy, and so we're going to take a deeper dive into coronary artery anatomy and how we really want to make sure that everything that we do makes sense anatomically. Because that's really what's going to tell us if we think this is coronary artery disease related, so this is like an acute coronary syndrome related, as opposed to someone who might be on medications or might have left ventricular hypertrophy or might have a left bundle branch block or some other things that cause abnormalities in the EKG that confuse us with MIs, but aren't. And so the whole idea is we're really going to focus on the anatomy and what the EKG is actually looking at. And so let's talk about coronary artery anatomy. We have the left coronary artery, we have the right coronary artery, and the left coronary artery is actually pretty small, and it splits early on, and you have this bifurcation where it gives rise to the circumflex that comes out to the left lateral wall, and then you have the LAD that heads down sort of the anterior area of the heart. And the right coronary artery is actually more complicated than it sounds. Not only does it wrap around to the posterior part of the heart, but then there's this branch that feeds the inferior area of the heart. And that inferior branch actually could be pretty long and sort of wrap up to the low left lateral wall, which we'll talk about as well. So the coronary artery anatomy is really important for you to think about when you're looking at the EKG. So here is a 360 view of the heart in animation. So if we look at this is the right coronary artery, that inferior branch, left coronary artery, circumflex, the LAD I missed, and we'll get it when we come around again this time. So here's that left main, LAD, circumflex. Here's that posterior view with the RCA coming around the back. So you could imagine anytime I would have some kind of a blockage somewhere, if I would clamp, so to speak, one of these vessels, anything downstream is going to not get blood flow, right? And we talked about last week that you have to have oxygenated blood getting to an area of muscle, or that area of muscle starts to die. And so that's what our whole idea here is that we want to be able to identify that somebody has something that they have to go to the cath lab for immediately for, hopefully, percutaneous coronary intervention, or PCI. So we're going to take this and we're going to add to it, and then we'll put the whole thing together. And I gave out a slide in the handouts that sort of puts this whole thing together that could be used as a reference. So if you don't have one, you can pick one up on your way out. So if we look at the heart, we have those coronary vessels that we just talked about. And when we think about those coronary vessels, right, we talked about the right coronary artery and that sort of inferior branch, and you have the left coronary artery, and that gives rise to the LAD and to the circumflex. Well, each of those areas I think about as a neighborhood. So we have the inferior neighborhood, we have the septal neighborhood, we have the anterior neighborhood, and we have the lateral neighborhood. And I like to think about the lateral as high lateral and low lateral as far as the neighborhood. So that is the distribution of a coronary vessel to what we're going to call a neighborhood. And then you have kind of a posterior view where you pick up the back part of the heart where that right coronary artery wrapped around to the back. And then this sort of got a little bit of a view of where the circumflex came down the left lateral wall. Okay, so now here's that same picture we talked about before, where you can see the coronary arteries feeding a specific neighborhood, each one. And here's a cartoon of a 12-lead EKG. And this cartoon of the 12-lead EKG corresponds to specific areas here. So for example, when I look here, in my mind, I should be thinking about, in this inferior area, when I look, or I should say, when I look right here on an EKG, in my mind, I should be thinking this. Now, like 15 years ago, someone tried to make this EKG that sort of showed you a picture, and it was like a whole series of like a vest of electrodes and all that, and it never really worked well. So this is where, you know, there's still a value in humans, because normally you would think the technology would be able to, you put the leads on and it would bring a picture of that up, right, with like a 3D image, and it should kind of blacken in an area that's dying, and you're like, okay, the work's done for you, right? It makes sense. It's been tried. It's never worked yet, okay? So maybe in 15 years, this talk will be obsolete, but for now, it's good. So the deal is that when I look at the EKG, this cartoon, and I look right here, in my mind, I'm thinking right here, and in my mind, I'm thinking, oh, that's that kind of inferior feeder from the RCA. And then when I look right here, high lateral wall, I'm thinking high lateral wall, I'm thinking, oh, the circumflex. And here, I'm thinking the septum. And here, I'm thinking anterior. And usually these sort of go together, because unless you have kind of a very specific type of anatomy, they pretty much are fed by the same. And then V5 and V6, I'm thinking about the low lateral wall. And so this is the cartoon put onto the EKG. And what I do then is I draw in my mind the neighborhoods. So I have sort of like this L, and I sort of have like this percent sign and that there. And you're just thinking about this every time you do an EKG. You're thinking about this, you're putting it back to the picture, and you got to think about the anatomy. Because if you don't think about the anatomy, then you're not going to be able to sort out what's MI related per se versus what's not. You have to figure out if it makes sense anatomically. So let me just back up for a second. When I come over here, would it make sense to have a lesion right here and right here hit you at the same time? No. In an MI, you have one culprit lesion. Okay, so maybe if someone's doing some heavy drugs or something, they could have land mining of their vessels, right? Maybe cocaine or something. But in general, you have one culprit lesion, right? It's bad enough that you have one lesion pop, so to speak. So you don't typically have more than that. And so you always have this idea of one culprit lesion, and that's why it should make sense anatomically that one vessel was occluded in one specific spot on that vessel. And then, sorry, I didn't test these slides, and some of the colors didn't come out well when I kind of copy and pasted into this presentation. But if you remember, we talked about the idea that we're going to be looking at the STsegment, and we're very concerned about something called STsegment elevation. But we collectively put this together and we said, when the heart has an insult, right? We called it an insult because it's not called an insult anywhere else, but it's another I word. So when you have any evidence of ischemia, injury, or infarction, we're concerned. And we have a few definitions as far as what might lead you to believe the person has ischemia. If you have STsegment depression, you're concerned about ischemia. If you have an inverted T wave, you're concerned about ischemia. If you have a flat T wave, you're concerned about ischemia. If you have STsegment elevation, we're concerned about injury. And when we use the term injury, we're talking about injury as being very acute as opposed to infarction that's sort of subacute. And when you have an infarction, technically, you have a big, deep Q wave, right? And so when we say a Q wave, even though this whole thing is always called the QRS complex, and even though this is still called the QRS complex, here, there's no Q wave. A Q wave is when the very first thing is heading south. So this person has a Q wave. I learned if the Q wave could hold water, it's concerning. So basically, if it's a little bit wide, a little bit deep, there's all different criteria. If you want to cover all the criteria as far as a Q wave, I just like to say that it's this is at least 25% of the height of the R wave. So this is like 50-50, right? So that would be definitely concerning, and that's obviously concerning. Sometimes you have a little physiologic Q wave, which is nothing. But when you see a deep, wide Q wave, you're concerned. So, but here's the deal. It's not good to think about this as sort of subacute and this is acute. Because as I pointed out last week, I don't know if this person's having an acute injury that just started 5 minutes ago, but in 2011 they had a big MI, or if they started having a big MI last night and they're already queuing in, so to speak. So I don't know. And so that said, collectively, we really put these two together and we say the person's having a MI, right? So if your machine would pick up on this and you looked at the read, it says acute MI. It doesn't say, and it might say, you know, acute injury pattern seen on or before whatever date, but whatever it is, this just group them together and say, are they having an MI or are they having ischemia? And collectively, I'm going to call this whole thing an insult. So just to review, we said that there's a lot of challenges with looking at a 12-lead EKG, and this is probably why people failed before making a machine that perfectly reads and places where the lesion is. And the idea is that you can have a whole host of things that cause these abnormalities. And so what we're trying to do is we're trying to figure out which ones are the ones that we're concerned about, that we activate the team, that you don't stop in the ER for much and you head right to the cath lab, versus who are the ones that it probably is something else. And again, it all goes back to really two things. Asking yourself if it makes sense anatomically, and asking yourself, is it directly related to probably one culprit lesion? Now, when I say one culprit lesion also, we're talking about acutely. If someone's been kind of pooping out for 3 days, it could, you know, all bets are off, and it really doesn't matter at that point anyhow, because we said the muscle's dead. So we brought up the concept of global versus focal, and global versus focal means that is the problem everywhere, which wouldn't make sense for one specific lesion, or is the problem just in one specific area, highly suggested that this is one specific lesion, because again, we say that acute MIs are caused by one single culprit lesion. Okay, so we talked about the idea of the EKG waveform morphology, so we'll just kind of review that. So if you weren't here last time, we talked about the concept that if you could start thinking about certain patterns that you see and certain views that you see, there are certain views that are more consistent with an MI. For example, I'll show you, you've heard about shark fins maybe, when you think about hyperkalemia, right? So I thought about that afterwards. I said, you know, I think I'm gonna leave that out because shark fins might be at the beach and that wouldn't be good. And so, so we'll leave that out, the shark fins. I don't have that as a picture, but we'll kind of talk about these beach-like things that make us more concerned that the person's having an acute coronary syndrome or MI. And we'll talk about which one we sort of loosely connect, right? And then I was asked last time, can I bring some examples? And so I have some examples when we talk about, when we vote on things and we look at it. So we talked about the idea that first of all, for starters, you have to have STsegment elevation. Okay, so in order to apply this, you have to have STsegment elevation. And so if you have STsegment elevation and it looks like a hammock, so the idea was if things look like things that are at the beach, those are concerning. And there's one thing that might not be at the beach, but if it's at the beach, then it's at the beach. And I'll show you what I mean in a second. So a hammock view, a surfboard view, a lifeguard chair view, sort of a roundish beach ball view. And then we have the water slide. And what we said is that the water slide, if you just see a water slide, you might be in the backyard of somebody in Owings Mills, right? But if you are walking down the boardwalk in Ocean City, and to one side you see the water slide by the hotel's pool, and the other side you see beach-like things, then you have sort of connected that water slide to the beach. But if you just saw the water slide, then you're going to be thinking, I might be in someone's backyard in Owings Mills. So that's the idea of the water slide. Okay, so we said a few, I don't remember what we said, but I brought a whole bunch of slides in, so I don't remember if I showed you these ones last time. I talk all day long somewhere about something. So a few rules. What happens in one neighborhood stays within that same neighborhood. So in other words, if you didn't have an umbrella and you walked outside this door and it was raining, you wouldn't be like, oh man, I gotta go out the back door to stay dry. Now, is it possible? I mean, I guess it's possible, but it's highly unlikely that if it's raining in this neighborhood, that it's not raining in the entire neighborhood. Now, if you were heading to Glen Burnie, would you just cancel your trip because you don't have an umbrella? No, because when you get to Glen Burnie, it might not be raining there. So even though it's sort of adjacent to here, but it's a completely different neighborhood. And so it wouldn't surprise us if it's not raining in Glen Burnie when it's raining here. But if it's raining here, it's raining here. So what happens in a neighborhood is happening in that whole neighborhood. And at least if you have more than 2 leads in a neighborhood, at least in 2 leads in that neighborhood, things would be happening. And again, that's when you're being concerned that this is acute coronary issue related. Now, there is a concept of reciprocal changes. You don't have to have reciprocal changes, but I'm going to use these to show you how I think about focal or global. Okay, again, you don't have to have reciprocal changes. See it less in like Septal MIs, but in general, you really do see reciprocal changes. They could be as subtle as just a flat T wave in AVL when someone's having inferior MI. So it doesn't have to be this big pronounced difference in a different area. But what am I talking about? So an opposite appearance in an opposite area. So that's what a reciprocal change is, right? An area that's reciprocal one to the other. So for example, these leads are opposite these leads. Now, these leads are kind of opposite these leads and this lead. So it's just a different neighborhood is having an opposite type of appearance and vice versa. So in other words, if I'm looking over here and I see something that I'm concerned about, then maybe I see an opposite appearance somewhere in here. And again, it could be as subtle as one lead, just a flat T wave, and you don't even have to have a reciprocal change. Now, there's also times that you hear someone say, oh, those are nonspecific abnormalities, right? So, and then you're like, well, how am I supposed to know? Well, you don't know, and obviously people can these are abnormalities and it can mean something. So, specific EKG in 2 ways. Number one, if it's all over the place and it doesn't really mean, but there's some typical things that you see. A typical thing that you see is in lead 3, it's not uncommon to look ischemic, kind of a inverted T wave. And in V1, it's not uncommon. So if you see this, you're not going to be like, oh my gosh, you're ischemic. That's like a very typical finding in normal people's EKGs. Okay, so I think we have enough foundation to now put together from what we learned last week to what we talked about this week to approach the EKG in a way that's a little more in depth than we did last week. So last week we really just took it from a surface level. This week we're going to drill down into really just a systematic approach to how to interpret a 12-lead EKG. So the first thing we said we did last week is we said, okay, is the rhythm okay and is the rate okay? Right? So in other words, if you're in the middle of doing a stress test and someone goes into VFib, right, we're not going to start breaking into neighborhoods, okay? That wouldn't be good. We're just going to act on it, right? So if the rhythm's okay, is the rate okay? And that, again, you don't have to sit there and have a whole dissertation about it and pull out calipers. You just want to know, is it okay that I can move forward with interpreting the EKG further? Okay, so after I say, okay, the rhythm's okay, the rate's okay. So remember we looked at this one? And we said, okay, that's not okay. That rate's not okay, and that rhythm's not okay, right? That person has wide complex tachycardia. That person is in V-tach. We don't, even though we have it on a 12 lead, right? We get something probably pretty significant very quickly. So we wouldn't move on from there. But let's say the rhythm's okay and the rate's okay. So then we're going to break it into neighborhoods. And when we break it into neighborhoods, we are going to just take a look at the EKG, and in my mind, I'm going to kind of create that look of that sort of cartoon, and I'm going to think about these areas, and I have my neighborhoods, and then I'm going to look at each neighborhood, and each neighborhood I'm going to ask myself, And always use like a systematic approach. Don't let your eyes do the walking, because you're just going to zoom, you're going to kind of zone in on something, you're going to miss everything else. So always do it the same way every single time. So basically, and don't let other people influence your brain either. I used to hate that. So you're sitting there in the ER at the desk and someone hands the EKG and you're like, you got a parrot in your ear, right? Do you hear when you think that, right? And I'm thinking like, why are you showing it to me? Like, you know everything. Why are you showing it to me, right? And why do you need my signature on top of it? So just kind of tune everything out. You got a minute or two to look at it. Just take that time, look at it, systematic approach, and then miss something. So I'm asking myself, is there any evidence of like STsegment elevation? Is there STsegment depression? Do I see anything that's concerning for an insult? And again, don't get hung up on the QAs, because you don't know if it's an old, you want an old, or if it's a old with sort of new, like, I don't know. So we're just going to, I'm concerned, this whole thing I'm concerned about. And then after that, we're going to ask ourselves, is the problem appear global or focal? Now, I'm not saying that you only have, that you have a global concern or only a focal concern. And I'm not saying that the EKG is perfectly normal all over, in most places except for one place. So in other words, you can have an EKG that has problems everywhere. But what I'm talking about is the same problem everywhere. In other words, would this person have land blasting of all their coronary vessels or not? And so in other words, when I look at this EKG looks concerning everywhere, right? But I have an opposite appearance in an opposite area. So right away, these, and we're going to look at reciprocal changes in a minute, we'll talk about, but when I look at this, I do have a nasty looking EKG everywhere, but it's not a problem per se, because I don't have the same problem going on here as I have going on here. So that's what I mean by, is it global or is it focal? I'm not saying is it a nasty looking EKG or not. What I'm saying is, do you have the same type of problem everywhere versus only in one area or one feed from a coronary vessel or series of maybe a proximal lesion that has more tributaries coming off of it, so to speak, that you have a problem in that area. And then what I use reciprocal changes for are to sort of confirm if it was global or focal. So in other words, here I have an opposite appearance in an opposite area than something out here. And so I'm using that to say, I think the problem is focal as opposed to global. Now, here's the big thing we got to do. So here I have some more slides about the same. So for example, here I have STsegment elevations, and here I have STsegment depression. So right away I know it's focal, right? It's not global. It might not make sense anatomically yet, but at least I don't have one big global problem. And then here's the million-dollar question. Does it make sense anatomically? So when I first started, so there was this cardiologist who, on the way down, they were wheeling the person to the cath lab, and he'd always call out where the lesion is. And I thought he was like, wow, that's like, he could start a religion, right? He knows before, and I realized like a year later when I started figuring this stuff out, I'm realizing that's not rocket science. What's sort of more surprising is when you ever heard someone go to the cath lab and it was a clean cath, when they had a totally nasty EKG, and you're like, what? How could that be? You know, you're waiting to hear the report back. You kind of call the little control desk there and you say, so what do you have? And that's when it's surprising. It shouldn't be surprising when you think you know where the lesion is and the lesion's there, right? That shouldn't impress you. So we want to know, does it make sense anatomically? Can I have a single culprit lesion that would have the findings of, like, let's say STsegment elevation within that territory? And so that's what I mean by does it make sense anatomically. So it wouldn't make sense to have bad look right here and bad look right there. right? Equally bad look. It wouldn't, that wouldn't make sense anatomically, right? Because everyone has a little bit different anatomy, but no one has a right that feeds their left and a left that feeds their right, and they cross. So it just doesn't happen. So you want to know that it makes sense anatomically. And then, just kind of putting this together, there are some things, and we'll just kind of go over these a little bit quickly. There are some things that mimic an MI. So there are some things that are pretty standard appearances that I sort of call it the EKG's final hug. And so you give that final hug, you want to know, do I see one of these things that might mimic an MI? So let's talk about the first one on that list for a minute. Left bundle branch block, because I don't remember if I pulled in all these slides or not, but a left bundle branch block in its own right could be an MI. Okay, you're not going to call it in as a STEMI. You're going to call it in as a concerning that they have a new left bundle branch block, but that in its own right could be an MI. So just note that to self. Left bundle branch block, new, which sometimes is more challenging to know unless you're called to a primary care office or something like that. In general, it's hard to know, but if you have the symptoms of an MI and you have a left bundle branch block, put the two together and be concerned just in its own right. Left ventricular hypertrophy has a certain appearance. It's not going to make sense anatomically, but it bugs people out, and that's where you really see water slides that are isolated. Ventricular pacemakers, we talked about the idea last week that pacemakers sort of are hard to notice nowadays, because if the machine doesn't tell you that they have a pacemaker, then you don't necessarily see a spike, and it could just look like a ventricular arrhythmia. And so that's something that also could mimic an MI because it gives the appearance of sometimes STsegment elevation. The most difficult one are wide complex arrhythmias. So when you see wide complex arrhythmias, especially tachy wide complex arrhythmias, those are very, very difficult, and you really have to put the things together as far as, and where you're going to make mistakes is probably there, because what happens when someone's having an MI? Often they're tachycardic, right? And so they're tachycardic, and so it starts to look very similar to, are they having an MI, or are they having a ventricular arrhythmia, or maybe an aberrant atrial arrhythmia? So that's probably the most challenging one. Early repolarization is very common, and I'll show you examples of all these and just quick ways of determining. Early repolarization is probably the most common. We used to do this thing at the hospital where we would do we used to call it the 50,000 mile checkup. It was a great gig because what we did was you bring someone in, and for $50 you do every free test you know how to do on somebody, and you're gonna find stuff on everybody, right? So you check their eyes, their ears, their everything, right? You check their blood pressure, their heart rate, you do an EKG. By the time you're done with them, you just made like 10 referrals. So before population medicine, it was really a good gig. So early repolarization, we used to see on like a lot of people, early repolarization. And pericarditis is another one, and then artifact, and we'll make some brief mention of hyperkalemia, because that's something that doesn't really mimic, but sometimes people confuse. So we're gonna take each EKG and we're gonna apply these rules. Remember the rules. The rules are, what's the rhythm, what's the rate? We're gonna break it into neighborhoods. We're gonna ask ourselves within each neighborhood, is there any concern for an insult? And then we're gonna ask ourselves, if that appears, what the insult appears to be global or focal. Do I reciprocal changes to support my theory that it's focal? And then we're gonna ask ourselves the million-dollar question, does this make sense anatomically? If it doesn't make sense anatomically, you're out. It just doesn't make sense anatomically. So there's no, everyone has a little bit different anatomy again, but you have heart anatomy. So that's going to be the big one. And then we'll give it the final hug, and we'll ask if there's anything that mimics an MI. So when I look at this, right, so if it was very dark in here, we'd be able to see the lesion that I made on there. But basically the idea is I take this and I say, okay, is the rate okay? And I say, yeah, it's okay. I can move on. And then I'm going to break it into neighborhoods, right? And so I'm going to say, okay, I have my inferior neighborhood. I have my high lateral wall. I have my septum. I have my anterior. I have my low lateral wall. And then I say, okay, within each neighborhood, do I have any evidence of an insult, right? So do I have anything that concerns me in here? And then when we ask that question, also think about the morphology, think about the shape of the QRS complex and the T wave and the ST segment, and ask yourself, is something that I told you is concerning? And so let's look at this and say, all right, inferiorly, do I have a concern? Absolutely, I have ST segment elevation, okay? It's sort of like a hammock, because it's not a water slide, right? It doesn't drop off, it holds water, is what one of the cardiologists also told me about that. I guess they have a lot of stuff that holds water. And then I ask, okay, I always go to the high lateral wall, and is the high lateral wall, is there anything concerning there? Yep, right, I have ST segment depression, and I have T wave inversion. All right, so I'm on to something. And then I say, okay, septum, do I have anything that concerns me? Sort of the same issue, right? I have this ST segment depression and T wave inversion. And then I say, anteriorly, do I have a concern? No. Low lateral wall, maybe, but nothing really that jumps out at me. But maybe a little bit of a yank down, so we'll go with that. And then I say to myself, do I have a problem? Yeah, I think I have a problem. And then I say to myself, is it global or focal? It's focal, right? And why is it focal? Let's jump to the next puzzle piece and say it's focal because I have an opposite appearance in the opposite area, so I have reciprocal changes to support my theory that it is focal. And then I ask myself, does this make sense anatomically? Can I have a lesion up here in this heart where it causes this to happen? And the answer is yes. Sort of that inferior branch, so to speak, of the RCA that feeds this is occluded. And so this person is having an inferior MI. And so we're just going to go through an example at first of every possible area that you could have an MI. And there's one that's very confusing, so we'll talk about that as well. Yes?
What's with V2?
What's with V2? It's reciprocal change. I mean, that's an opposite area. Look where V2 is.
From the inferior?
Well, no, so V2, so where's this? It's right up there. Where's V2? Right next to it. I mean, it makes sense that they kind of hang together. Okay, so as far as lesion-wise, so here's the lesion, right? So it makes sense. That person's knocking off all this territory down here. Now, when you have in the state protocol RV infarct, or when you take an ACLS class, they say RV infarct. Is this an RV infarct? No, right? I mean, an RV infarct, you're knocking off all this in the back. This person has an inferior MI. So it's not that we have to completely not think about nitro for this person. That's probably going to be okay for this person. This is not an RV infarct. It would have to be more proximal for that to happen. So just note that to self. Let's look at this one. Now, I could probably get a better example, but this one actually kind of shows you how much you have to look very, very closely. So again, is the rhythm okay? Is the rate okay? And some of you are looking and saying, well, maybe they're a little bradycardic. Okay, but it's okay, right? I don't need to do anything for this person. I just need to move on pretty quick, right? So then I'm going to break into neighborhoods. I'm going to say, okay, inferiorly. Again, I always start here. Inferiorly, do I have anything that's concerning me for an insult? Yeah, I got ischemia going on, right? And it isn't 2 leads out of the 3. So, okay, we'll kind of take note of that. And then I say, high lateral wall, do I have any concern? And yeah, I have ST segment elevation. Again, it's a little bit more subtle than other examples, but it's there. So I have a concern going on right here. Okay, how about here? Septally, doesn't look too bad. Anteriorly, doesn't look too bad. Low lateral wall. You know, maybe a little bit of concerning appearance might show up, but I'll explain that in a moment. So basically, do I have a problem? Do I think I have a problem? And for sure, yes, and maybe yes. And then I ask myself, is it global or focal? Focal. Do I have reciprocal changes to support my theory? Yes. And then I ask myself, does it make sense anatomically? And it does, right? Because somewhere after the bifurcation where the circ comes off of where the left main split into the circ and the LAD, it looks like their LAD is pretty well spared, but their circ is not, and they have a pretty long circ, so that's why this area got picked up as well, but they're having a lateral MI. And then you can see the lesion would be over there, and I'm taking out the lateral wall of the person's heart. And then we have the septum. Now, septal MIs are probably the ones that get missed the most. They're the hardest to notice. And so let's just kind of look at it. You have to have a pretty specialized anatomy to just have a septal. Because think about it. In general, the left main, when it splits into the LAD and the circumflex, the LAD is covering all that territory together, the septum and the anterior. But you could have kind of an isolated anatomy in some. So again, is the rhythm okay? Is the rate okay? Maybe they're getting a little tacky, but it's okay. I can move on. And then I'm going to break it into neighborhoods. I'm going to say, inferiorly, do I have any concerns? Yeah, nothing really exciting. And then I'm going to say, high lateral wall, do I have any concerns? Nothing really exciting. Septally, do I have any concerns? Yeah, big time, right? And then anteriorly, do I have a concern? No. And here, do I have a concern? Low lateral wall? No. So I think, okay, do I think I have a problem? Yes. And I say to myself, okay, is it global or is it focal? It's focal. Again, you don't have reciprocal changes, but now let's think. Anatomical, did this happen? Yes. The person has specialized anatomy, so to speak, and their septum has a feed and getting knocked off.
Does that little blip not make that a Q wave? Those are not
Where?
Q waves, correct? V1 and V2 do not have Q waves, correct? Are they Q?
This is probably a Q wave. It's hard to see from here.
But in V2, probably not. There's a little upstroke. It's hard because it's not consistent with V.
Well, okay, so I would say it is. But the thing is this. Again, think about that car. The question is, would you have a Q wave everywhere? And then again, think about that view of the car. It's just a matter of what view you're looking at. If I don't know, if it has an extra long bumper or something, you know, it's like you're standing there and you're looking at it. Do you see it? Do you not see it? It's all a matter of what view you're looking at. So here's where I kind of made a lesion coming off of the LAD. But again, usually this whole area is fed and that's it. Okay, now you could have mixed bags. You think about it, the more proximal the lesion is, the more areas that could get knocked out by one culprit lesion still. But this one here, it took me years doing this to finally have the guts to go up to one of the cardiologists and ask them how this is possible. Because it doesn't make any sense until you think about it and you get explained if it gets explained to you. And so there is an animal called an Infer MI. Now let's think about that. Shouldn't this be fed by the right and this fed by the left? So let's look at it. We're going to say this. We're going to say, okay, is the rhythm okay? Is the rate okay? Yes. I'm going to break into neighbors. I'm going to say inferiorly, am I concerned? Yes. High lateral wall, am I concerned? Well, I'm concerned, but it's a different something, right? And then I'm going to say, okay, septally, do I have any concerns? Yes, but it's a different type of insult than over here. So I think here I have ischemia. And then here am I concerned? Not really. And here am I concerned? Absolutely. So then I say to myself, okay, is it global or focal? And because I have two different types of concerns, I say it's focal. And then I ask myself, are the reciprocal changes to support my theory? And I say, yes, right? This is reciprocal to this. And then our question doesn't make any sense. Because I say, does this doesn't, right? But it does. And the reason why is this. I'm going to jump to this here. Depending on the person's anatomy, this is fair. Circle. in this case, this is getting fed by a so your low lateral wall could very well be fed by a branch of the RCA. And so that's why it actually does make sense anatomically to have an inferolateral MI, because you have a lesion to that same vessel that causes an inferior MI, and it happens to be extra long and wrap up to the low lateral wall. So this does make sense anatomically, even though seemingly it wouldn't. Okay, and then moving on, you could have, is the break into neighborhoods. Do I have any concern over here? Yes. What kind of insult do I have? Ischemia. And then over here, am I concerned? Yes. And what do I think I have? Right, so, well, or at least injury, right? And then what do I have over here? Septally, right? Problem, right? Got some surfing going on. And then what do I have over here? Same type of a situation. And what do I have here? Same thing. And so, again, from the surface, you're like, oh, this is global, right? It's globally bad looking, but it's not a global problem, right? Because I have reciprocal changes to support my theory that it's actually focal. And then you ask yourself, does it make sense anatomically? And now think about it. Now, you're never going to get an EKG. I won't say never because obviously someone may have gotten this before, but you typically don't get an EKG of someone with left main disease and having a big MI because they're dead before you get the EKG. But when we look at this, it's pretty common. Have you heard of someone getting like kissing stents? It's very common by the bifurcation of where the circumflex and the LAD branch off to have a lesion there. That's actually pretty common. And so think about it. It does make sense anatomically. If I knock off the LAD, let's go to the, if I knock off the LAD and I knock off the circumflex, I've taken out all of this, V1 through V6, and one in AVL. Right? So it actually makes sense anatomically because that one lesion takes out the high lateral wall, it takes out the low lateral wall, all the distribution of the circumflex, and it takes out the septum and the anterior. And once in a while, you'll see this, but this got spared. And you're like, how could that get spared? Because that person was lucky enough to have feed that, right? Because they got that long RCA branch. And so sometimes it can really work in your favor. Okay, I mean, they don't call it collateral flow, but that person really has kind of collateral flow from the other side of their heart going all the way over there. Okay, and then the last one is usually sort of a mix. Usually it comes together anyhow, and that is anteroseptal. And so here we have and you can imagine what got spared. So here we say, okay, the rhythm okay, is the rate okay, and I break into neighborhoods, and am I concerned? Maybe I see, well, not maybe, but I do see an ischemic type of an insult. High lateral wall, here it looks okay. Septum, it doesn't look good, but that is a water slide, note to self. And here it doesn't look good, and this is a water slide. But then this doesn't look good, and here's a hammock, and right away I've pulled Ocean City together for me. I pulled the swimming pool together with the beach. I'm concerned about all of those. And I asked, okay, is there a problem? Yes. And then I ask myself, are there reciprocal changes to support my theory that it's focal versus global? And the answer is yes. And then I ask myself, is there a lesion that can make this happen? And the answer is yes. This person, they spared their circumflex, right? So their lesion is just beyond the bifurcation of the LAD and the circumflex. So they have a pure proximal LAD lesion, but they spared the circumflex. So this is okay, but all this isn't. And so that's common finding in an LAD lesion. So that's you can imagine what the lesion is and then what got spared. So again, if you always think about that picture of the heart when you look at an EKG. So when you look at an EKG, kind of subliminally, the other picture should be what's in your head. And thinking about, okay, where's the lesion? Does it make sense anatomically? Can this happen? Okay, the concept of a posterior event, this is something that, maybe you're going to do a right-sided EKG. Typically we don't. I know they promote it a lot, but typically it's not what we do. If you would go into the emergency room and you would ask them how many times they did a right-sided EKG, they do EKGs all day, every day. So it's not really something that everyone gets. But if we think about it, if we have some findings of an inferior, if we have findings of an RCA lesion that's sort of more proximal to where that inferior came out, I might knock off the inferior and the entire posterior. And that's when you talk about things like an RV infarct. And so people ask me like, well, what is that? And it's really, I think about it like this. What is most anterior to the posterior? In other words, I'm putting my EKG on their front pretty much, right? I mean, there are some tricks of throwing V4 on their back and stuff like that. But in general, I'm doing an EKG, the eyeballs are in the front. But remember, I told you, you see how energy comes towards you and away from you. And so when I'm looking at, if I want to look at the back, so to speak, right, because the heart's sort of transparent to the EKG machine, if I want to look at the back, which anterior leads are most anterior to the posterior that I might see an opposite appearance if I'm kind of looking towards their back? And that'd be V1, V2, V3, correct? So what I learned is that if you have STsegment depression, V1, V2, V3, think that you are seeing an opposite appearance in their back from their front and be concerned. And those get missed as well. You'll have somebody who's like dying in an ER bed and they have an EKG that's obvious that there's a posterior event. So basically the general rule is, in general, now you have to think about the anatomy. If you have a proximal RCA lesion, knocked off the bottom, so I knocked off this, and I knocked off the back with an opposite appearance and an opposite what is most anterior to the posterior. But here's where people really mess up, and that is right here. When you sort of have an isolated posterior. So in other words, you've spared that branch to the inferior. You got someone with no blood pressure who's pooping out, and all you see is STsegment depression, V1, V2, V3. You could imagine that that's where you don't only want to go necessarily, well, first of all, you're driving pretty fast at this point, right? But you also don't want to only go by, I can infer that what's most anterior to the posterior. That's definitely appropriate, probably the most appropriate time to start looking at a kind of a right side EKG or flipping V4 in the back to look at a posterior view, because that is where this person is going to die if something doesn't happen big for them very quick. And sitting there in an ER bed because they don't have an obvious sign of an MI is bad. Those get missed. Now, AVR, when I went to school, I was taught that you ignore AVR, and now we're taught that we don't ignore AVR. So AVR was one time called in a paper I saw the neglected lead. It's not my term, it was a term that a group called, I think it was in JAMA. And basically, there are some findings. A lot of these things that they find are just by looking at many EKGs and just starting to see that there are some things that they see kind of in hindsight. So STsegment elevation in AVR with STsegment depression that is sort of in the it could be all over the place. Often it could be like V4 through V6. It could be STsegment depression areas like 2 and like lead 1 and lead 2. But basically, if you see like really a lot of STsegment depression, together with STsegment elevation AVR, they have found that that correlates with left main disease, and that's bad, right? So here's another example. This is somebody who has STsegment elevation AVR, and they have pretty diffuse STsegment depression. Then that person, you want to really be concerned that that person has main disease. So that's something that's now thought of as concerning. And then after I look at the EKG and I ask myself all these anatomical things and does it make sense and do I think they're having an MI, I do the final hug. And so time-wise, I think we have time to let's spend 10 minutes on this, then we'll take a 5-minute stretch, and then we'll do some cases. So again, left bundle branch block is a sign when it's acute that this person's having an MI. Now, I think this slide's out of place, so let's jump to here. You may have heard of the turn signal method, which is probably the most EMS-y way of knowing that someone's having a left bundle branch block versus a right bundle branch block. And basically the idea is the only thing you got to remember is V1. You got to think the terminal part of V1, meaning the final part, the part of the QRS complex in V1 that's the terminal part of the QRS complex, the part of the QRS complex that's closest to the T wave. So basically what you're going to do is you're going to think about you're driving a car, and you're going to think of, okay, I'm driving my car, right? So I'm driving, and you're going to ask yourself, is the terminal part of the QRS complex in V1 up, or is it down? If it's up, which way am I turning the turn signal? If I'm turning it up, which way am I turning? I'm turning to the right. Good. If it's down, which way am I turning? To the left. So if you have a wide QRS complex, right? So in an adult, greater than 3 small boxes, if you have a wide QRS complex and you want to know if they have a left bundle branch block, it's the terminal component of it, in V1, the terminal component of the QRS complex is down. Another just a quick down and dirty way is, if it looks like a PVC in lead 1, just kind of, it's usually like in V1, V2, V3, it looks like a PVC, just go with left bundle branch block, okay? So that's just something that mimics an MI, because if we go back to this one, you can see how there's things here that concern you, right? Now, it's a water slide and no other findings around it. But when you do your final hug, you look at this and you're like, oh, they have a left bundle branch block. You see what I mean by that PVC look here? Sort of looks like a big PVC. That's just the way you look at it, you don't have to think. Okay, so let's just run through a few other things. Left ventricular hypertrophy. So just to keep it really, really simple, if your QRS complexes are going off the map, okay, so there are criteria. So basically, if you take the deepest S wave in V1 and V2, and it's kind of hard to see, I know, and you take the tallest R wave in V5, V6, and every little box is a millimeter, and you add up the R wave plus the deepest S wave between this and this, if you add it up and it equals greater than or equal to 35 little boxes, think LVH. But it's even easier than that. You don't have to waste a lot of time with this. When these are going off the chart, sometimes the EKG machine has to even like bring the whole the whole V4 down because there's no room for it on the paper. When they're going into each other, the QRS complex is so tall, think LVH. Now, there is a very specific finding in LVH. It's not uncommon to have this appearance of what looks like STsegment elevation over here, but again, it's a water slide. And this very ischemic appearance here, that's very typical. That's the typical look in LVH. So like here's another example. It's the typical look of LVH. As soon as I see this, I'm like, okay, there's LVH, right? There's nothing, I mean, why? I mean, think about how thick that muscle has to be to suck down that electricity for such a prolonged period of time that's giving me that appearance, right? So people look at this and like, okay, it's very ischemic looking. The typical findings are, it's sort of, you have like water slides in here and it looks very ischemic here, but then I'm like, oh, you know what? This person has LVH. Now, one little thing I'm going to tell you, don't get into a trap. Can people with LVH, I mean, they're starting off with a heart problem, right? Obviously, they either had hypertension for a long time or some kind of other cardiomyopathy for another reason. I mean, can't they have an MI? Absolutely, right? So you could be having an MI and have LVH, but you just want to sort of, if they have no symptoms, right? You go to someone's house because they said that maybe they have hypertension and they can't get a read on their blood pressure monitor, and you get a really high bleed, you get a really high read, and you get an EKG because you figure, okay, maybe I'm going to get an EKG on that person, and they didn't complain about nothing, then I'm thinking more LVH. Now, if this person's going like this and they're huffing and puffing, I might acknowledge on the radio that they have LVH, but their signs and symptoms are concerning maybe for an acute coronary syndrome or for an MI. So when I tell you all these things, people with pacemakers, they've already defined themselves as having a heart problem. Might they be having an MI? Yes. People with LVH, right? So all these things are fair game, but there's just some specific findings that might tell us it's something else. We said ventricular pacemakers, right? Ventricular pacemakers make us often make it look like they're having an MI. Right? So this kind of is, you're like, oh my gosh, right? But does it make sense anatomically? No, it doesn't make sense anatomically, right? The pacemaker is making this look. But again, people with pacemakers could have an MI, but you're not going to call this in as a STEMI. You're going to say, I have signs and symptoms consistent with an MI on somebody who has a pacemaker. Now, this one I find the most challenging. When you have a aberrant rhythm or ventricular rhythm and trying to differentiate, you're allowed to maybe not be right 100% of the time. Just err on the side of caution. But again, does it make sense anatomically is what's going to make you say, maybe I think this is something else.
Does the upright AVR lend yourself to VTAC more than anything else?
No, I mean, I don't look at AVR for VTAC. I look for AV dissociation. This is a little bit irregular to be VTAC. There's all this criteria about concordance in the precordial leads. Here you don't have concordance because these go this way, these go that way. So I probably wouldn't put it at VTAC. I'd put it at maybe, no, I put it at AFib with RVR with an aberrant type of a pathway. But again, can people with AFib have an MI, right? So you have AFib, you're having an MI, it gets fast. So again, everything I'm telling you, you gotta sort of take a step back and look at the big picture. Early repolarization, we'll talk about this one and another one, we'll take a little break and then we'll get into our cases. Early repolarization is where you really, I felt really inadequate, like my first probably 10 years doing this, because you sort of, you flash the EKG by a cardiologist and you're like, oh, right? And they're like, they just walk by and sometimes they won't even acknowledge that you showed them something, right? And you're like, wow, so of course, no one I worked with does. So they're retired. No, I'm just joking. So anyhow, so the deal is that there's this idea of early repolarization, and early repolarization though is where you really see water slides, and this is what I learned. If you have STsegment elevation that's not a water slide, but it's caused by a notch, think early repolarization. So in other words, right here, the only time I'm really concerned was caused by a notch. Okay, so these notches are, I've heard people call it a J-wave, but the key thing is these notches, so it looks like a water slide, and the only time I'm concerned it's caused by a notch, think early repolarization. And then we have pericarditis. So pericarditis is, there are some very specific findings, but again, it's not going to play itself out that the person is having an MI anatomically, because the entire pericardium is inflamed. And so typically the findings are you have STsegment elevation more globally. You'll hear the term you have a short PR interval, and that's, so, I'm sorry, that's different. That's WPW. You'll hear people say that you have depressed PR interval. So here's an example. You have a depressed PR interval, you have diffuse STsegment elevation, and you have a reciprocal change in V1. That's textbook. The person's having pericarditis. Now, I'll tell you though, I data mined like the electronic medical records system for a huge organization and put in the terminology as the final diagnosis of pericarditis to find this perfect textbook example. So that's why you'll hear someone going to the cath lab, and then you're like, what happened? And they're like, well, they had a little pericardial effusion. They were told to take NSAIDs and get a follow-up echocardiogram or something like that, right? So it's not always perfect, but usually when you have pericarditis, it doesn't make sense anatomically as far as being one culprit lesion. And the other thing to note to self are just the symptoms, right? Typically, the person feels worse when they lay down. They feel better when they sit up because there's less pressure on their pericardium. You know, sort of some symptoms kind of help you with that. And then we said, I showed you this example last week, artifact, don't read into this EKG, do another one, right? Because we said that this looked like they were having a septal MI or an anteroseptal MI, but that is no baseline there. And then we have one more slide before we take a break, and that is something that people confuse with a STEMI, and that's when you have these really peaked T waves. And when you have peaked T waves, you're thinking hyperkalemia. So again, it doesn't make sense anatomically, but just note to self, these peak T waves, I think this person had a potassium of like 9 or something like that. And so peak T waves, think about hyperkalemia. So what we talked about so far before we take a break is we talked about our systematic approach of a puzzle of determining what an MI might be or where it might be. And then we talked about sort of just the quick final hug about some things that it won't necessarily make sense anatomically, but there are some things that make the similar type of abnormalities, and they're not an MI. So let's take a 5-minute break, just because I went over a little bit, and then we have some good cases and stuff that we'll vote on. All right, so we're going to pick it up again, and I started with just some basic things, and then we'll just keep growing. And the idea is that everyone has a clicker in front of them, and the only thing we're going to use is number 1, number 2, number 3, number 4. And you can vote as many times as you want, but it just keeps overriding your vote. I'm not necessarily going to wait all 30 seconds. When I see I have a bunch of votes in, we'll just keep moving on. But this way, everyone has the opportunity to think without having anyone dominate the conversation. So are we ready? Yeah. Okay, so let's vote. So what neighborhood is that? So far I have 0 responses. Are the clickers working? Here we go. Nah, we're getting clicks. There we go. Okay. Yeah, and point the clicker up here, because the transducer or whatever it is right there. Transreceiver, yeah, it's right here. Yeah, absolutely. Okay, good. So inferior, good, right? That's the inferior area. So if you're online, right, I'm kind of, it's hard for me to describe where I'm pointing, but I'm over here by 2, 3, and AVF. And so AVF would be inferior. Good. Okay. So inferior. Excellent. Now let's look at this one. What neighborhood is that? When we hit 10 votes, we'll call it. How's that sound? We're only at 7. Okay, so so we have a bunch of folks said lateral, and we had some folks say anterior. So let's look. We're in the upper corner of the EKG, and we're by lead 1 area. So we said that this is high lateral wall, right? Anterior is all the way over here. And so the correct answer is lateral. Okay, excellent. And then another neighborhood. What neighborhood do we have here? All right, so we had a whole bunch of votes already, so we called it. So we're here on where you see the blue ring, and that's V5 and V6, which is the low lateral wall. So it'd be lateral, right? Because again, to review, anterior is over here V3 and V4, and so that wouldn't be. And then septal is V1 and V2, so it's close by, but this area is the low lateral wall, V5, V6. Okay, so what neighborhood is this? Because this is what we're thinking of when we do the EKG, and we're putting in our mind this picture. And so we need, oh, there we go, we got 10 votes. And so this is the anterior area here where it's red. And so I agree, anterior. Now, if you said septal, I mean, in general, they're together. But technically, if they were separated, V1 and V2 is the septal area, and this little bit right there is the septum. Okay, what blood vessel is this? So we're thinking of our coronary artery anatomy, and we want to know, does it make sense anatomically? We have to know what blood vessel that is, right? Okay, good. So we have LAD. So I agree with the LAD. Now, as far as left main, it could be. It could be left main. Well, I shouldn't say that because I'm looking at the LAD, but your findings in your EKG, they could be either. But the left main is actually really small. It's up here. So is the LAD. And did I make my sarcastic remark about the Widowmaker last week? Yeah. Or 2 weeks ago? Okay, so people are like, is that the Widowmaker? It's like, who cares, right? If they're dead and they were married, it was a Widowmaker. So it really is irrelevant, but somehow people are very fixated on if their loved one died from the Widowmaker. That's what I'm saying. Yeah, so if you die, it was a Widowmaker. So anyhow, but people are truly fixated by that. Okay, so let's go back, let's keep on track with our beach theme. And we're gonna look at this EKG, and we're gonna ask ourselves, what's going on? We got 30 seconds to figure out what's going on. Okay, so we got a whole lot of opinions going on here, right? All right, I'm going to go with the acute MI one. And the reason why I'm going to go with the acute MI is because when I look at it and I say, is the rhythm okay, is the rate okay, and I say yes, and I look in this area here of 2-3 and AVF, and I see a little bit of a concern for ischemia, and then I look at the high lateral wall, and I'm seeing a little bit of STsegment elevation, and here in septally, V1 and V2, I see STsegment elevation. This is like the most beautiful lifeguard chair I've ever seen. And then here, I see in V3 and V4, I see kind of a surfboard appearance. And V5 and V6, I see sort of like a hammocky type of appearance. And I say, am I concerned? Yes. Is it global or focal? even though this EKG looks nasty, but I do have kind of the appearance of a reciprocal change in the inferior area, like in V3, in lead 3. And so I asked myself, does it make sense anatomically? And it does, right? I have like a bifurcation lesion where the LAD and the circumflex kind of split, and this person is having an an anterolateral MI. Okay, so there we go. And so I just gave this away, so we'll just move on. But we think that they're having an anterolateral type of event, right? So that's what I'm concerned about. Okay, next one. Let's take a look at this and see what we think, and then we'll talk about it. Okay, good. I agree with you. It's early repolarization. So I ask myself, is the rhythm okay? Is the rate okay? And I say yes. And then I ask myself, in the 2-3 Navy F area, am I concerned? And not really. Remember, I told you could have that sort of non-specific EKG, but that's fine. That's fine. We'll go with this being maybe a concern for ischemia. And what do I see over here? I see a little STsegment elevation. Okay, but I heard some good comment. It's caused by a notch. And what do I have up here? STsegment elevation caused by a notch, right? And now right away I know this doesn't make sense anatomically. So, and I don't see except for maybe where there's a notch. So right away, all the STsegment elevation I see is caused by a notch, and it doesn't make sense at all anatomically. Bam, early repolarization. So excellent. And what do we see here? We're going to see if you're a good test taker or not. Okay, see, if you want to get people on a test, you put the same abnormality twice. So anyhow, it's the same abnormality. Okay, so early repolarization. So again, I look at this and it does not make any sense anatomically, and you see a notch that's causing all my STsegment elevation. Again, it doesn't make sense anatomically. You can't have a lesion here, 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 that wouldn't be a culprit lesion acutely. And so early polarization. Okay, so a little Maryland theme. And what do we think we have here? Okay, so I agree with the left ventricular hypertrophy and the look of early repolarization. So again, right away, as soon as you see these suckers going off the paper, early repolarization. Even though technically you don't look at V4. What did I say? Early repolarization. Oh, early repolarization, yes. I'm sorry, no, left ventricular hypertrophy, you see them going off the charts? Okay, so, but I do see some notches in here, like right over here. So maybe they have early repolarization as well. But again, I'm not concerned about this STsegment elevation because it's caused by a notch. Okay, so if it's caused by a notch, I'm not concerned about it. And anyhow, it doesn't make sense anatomically. And the global ischemic appearance is very typical. This is very a typical appearance of an ischemic look in left ventricular hypertrophy. Okay, so what do we see here? It looks like the voting didn't pull into the slide. Oh, here we go. Okay, good. So we're very concerned about an MI here, right? So if we look here, we see that if we say, okay, is the rhythm okay, is the rate okay? Yes. We break into neighborhoods and we say 2-3 AVF. I see some STsegment elevation. And here we see in high lateral wall, lead 1 and AVL, we see some STsegment or some inverted T wave. And then here we see septally, V1 and V2. I see some ischemic appearance, some inverted T waves. And then V5 and V6, I'm sorry, V3 and V4 anteriorly, looks okay. V5 and V6, maybe a little bit of STsegment elevation. So I'm concerned that this person's having what kind of MI? They're having an inferior, maybe an inferolateral, but we get the idea of where the lesion might be, sort of that inferior branch feed off of the RCA. Okay, another case. Okay, good. So we think the person's having acute MI, and I agree. And so we're going to say, is the rhythm okay? Is the rate okay? And then we look here at 2, 3, and AVF. And are we concerned? Maybe there's a little drop of ischemic appearance, but not really. And then high lateral wall. I'm concerned about STsegment elevation. And then I look at the septum. Definite, right? Definite STsegment elevation. V3 and V4 anteriorly, STsegment elevation. V5 and V6, STsegment elevation. So what do I think I have? I think I'm having an anterolateral MI, right? So I have a proximal LAD lesion. By the bifurcation, I've knocked off the circumflex and the LAD, and it's causing that appearance. Okay, so again, I agree. This person's having an acute MI. And so how do I approach it? I say, is the rhythm okay? Is the rate okay? Yes. And then I ask myself, break into neighborhoods inferiorly, 2, 3, and AVF. I'm concerned about STsegment elevation. And then high lateral wall, 1 and AVL. I see some ischemic appearance. And then we have septally, ischemia, Anteriorly, V3 and V4 ischemia, V5, V6, I see STsegment elevation. And what's this? That extra, was that on this one? No, okay, different one. So do I think I have a problem? Yes. So the reciprocal changes support my theory of an opposite appearance going on in the opposite area. Yes. Does it make sense anatomically? And again, when you first went to school, it wouldn't, but now we know it does because I can have that extra long branch from the RCA, and so I could have an inferolateral MI, and it does make sense anatomically. And so I just gave it away. So, right? Good. Okay, so we have like 2 more cases, and then we could field questions. So this kind of goes back to last week. Okay, so AFib with ventricular paced beats, I agree. And so the thing that's interesting, I look at this as like, is this normal for this to happen? Like, is the pacemaker, is it acting appropriate? And the answer is yes, because think about it. Remember I showed you that last week, the person looking over at the fence, and they're seeing these R waves, and so it sees an R wave, and let's say the pacer is set to go at whatever rate, right? And the pacer is kind of programmed to say, if it goes less than this rate, in other words, if I have this amount of a gap and not see a ventricular impulse, go ahead and fire, right? So this is pretty slow right here, right? What is the rate here? It's hard for me to see up there. So let's say, how many boxes is it? So I'm going to say like 300, 150, 175, 60. So maybe the rate's let's see, 300, 150, 175, 60. So the rate's approximately 60 something. So maybe that person's pacemaker was set for them to be going a little faster, but it makes sense because it wouldn't make sense here. Here's pretty fast, but that makes sense there. And then maybe it hit them again, and then they went on, and then look, they slowed again, and then they slowed again, and then they picked up again. So it makes sense to see that. But you wouldn't be concerned that this person's having a whole lot of ventricular ectopy because we see that is a ventricular paced beat. The other thing, note to self, and this is where the telltale sign is, what's a PVC? It's premature. Now you could have a ventricular escape beats, but in general, if someone has a pacemaker and it's sort of appropriate for the rate, then think pacemaker, even if you wouldn't see a spike. This might be the last case, so make it good. We're all over the place, aren't we? Well, when I look at this, so is there a wide complex? And there is a little bit of a wide curious complex here. So, right? I mean, it's maybe borderline, but what grabbed your attention, I see, is that kind of that peaked T wave, right? And that peaked T wave would be concerning for hyperkalemia, right? They call the EKG the poor man's lab, right? Because EKG costs you a penny, and sending off to a lab is expensive. So, you know, you get these calls when your local assisted living gets a lab value back and tells them to call EMS for a trip to the hospital because there's a high potassium level. The key thing is that you want to get the EKG to see if it sort of correlates with, you know, end organ damage, so to speak. So it's pretty difficult to get, if you have a completely normal EKG, it's at night, it's very difficult to get emergent dialysis on somebody who has hyperkalemia because they're not showing any concerns for hyperkalemia unless they have a peak T wave. But this is a complicated one, right? I mean, we don't know really 100% by this EKG, but one thing we do know is it really doesn't make sense anatomically that this person was, certainly that this person's having an MI. And it looks like I have one more. Okay, so we're kind of a little bit all over the place, but let's analyze it first before we say what it really is. So when I look at this, I say, okay, is the rhythm okay? Is the rate okay? And then I'm going to break it into neighborhoods. Ask myself in 2-3 AVF, inferiorly, do I have any concern? And the answer is not particularly, maybe whatever, maybe a little bit of an ischemic appearance. High lateral wall, am I concerned? Not really. And now septum. Okay, maybe I'm. Is it a beach? It's more a water slide, right? Okay, then I look high. I'm sorry, I look at anterior V3 and V4. Okay, so I see maybe water slides, and then I look at V5 and V6, low lateral wall. Maybe some ischemic appearance, okay? And then I say to myself, okay, do I think I have a problem? Maybe. And then I ask myself, does it make sense anatomically? Is it global or focal? Maybe you're going to say it's focal. Does it make sense anatomically? It sort of does. And I ask myself my final hug, and I say, do I have anything here that mimics an MI? And in this case, I do have a left bundle branch block, right? I have a very wide QRS complex. And when I look at the terminal component of V1, the final component of V1, am I turning down or am I turning up? I'm turning down, so I'm making a left, so I have a left bundle branch block. And again, after you look at these all the time, you're like, okay, they look like they have a huge PVC, V1, V2, V3, bam, left bundle branch block. And so that's, again, in its own right, that could be an acute MI. So that's all I have. So thanks for listening. I had a great time. Hopefully you did. And maybe we'll talk one day in the future. Thank you. Questions? Yes.
If you have a really wide, complex tachycardia in a patient with a pacemaker, can the pacemaker differentiate if they have an internal defibrillator?
Yeah. So the question is if you have a defibrillator implanted, right? You have an ICD. Every ICD has a pacer mode to it. Typically, they're only in there as a backup. But sometimes someone has both modes going on at the same time. So the question is, could the pacemaker differentiate between if it's a ventricular arrhythmia or is it just a wide complex? The answer is yes. So the pacemaker and the defibrillator, the defibrillator is actually getting its read off of the myocardium. So in other words, you can interrogate the pacer and you can see exactly where the thing is coming from. Or the ICD. So it's not that it's not like an AED that's looking for just rate and width. The actual ICD is looking at the myocardium and picking up on that zone as far as what it is. Okay, and there's a lot of tweaking that goes into them. Sometimes they fire inappropriately, right? That's why we have the protocol to put a donut magnet on it, right? How many times have you heard you hear the dispatch radio and they talk about for an ICD firing? Right? You've never heard it? Isn't that the best protocol in the entire protocol book? You know why? No? I submitted it, but anyhow. It's the most important one. No, it used to drive me crazy. Now, I'll tell you, I wanted it to be a little bit different. I wanted it that no matter what was happening, if it was correctly firing or incorrectly firing, but if it was correctly firing, but for an inappropriate circumstance, I wanted you to be able to abort the firing and give the person amiodarone. But that was overruled. So in other words, you can have someone that is completely stable in the thing's firing, but the powers wanted it to fire. In other words, I wanted you to be able to put the magnet on it and treat them like you would in the real world. And then only if they're unstable, go with letting it fire by just taking the magnet off. But anyhow, so yes, they are very smart, those machines.
I've had two patients who initial impression was VTAC. They had wide complex tachycardia, chest pain, the whole 9 yards. And I always asked them to valsalva. They both had pacemaker defibrillators.
Mm-hmm.
And both of them broke with valsalva. So it's always worth
Yeah.
a try, I think.
So the comment is that someone had a pacer and they were tacky, and valsalva broke it, suggesting that it was like an SVT. Now the other thing with a pacer, there's another big misconception out there as far as pacers and defibrillators. So everyone thinks that if you put your magnet on somebody's pacemaker that shuts it off. Okay, that's not true. What it does is it force paces it at your maximum magnet rate. So in other words, what they do is they set these pacers in a way that it detects the magnet and it paces at the upper magnet rate. And the reason for that is every time you put a pacer in someone or you want to interrogate it or you want to check it, do you really want to have them sit in the office for 4 days until the pacer happens? Maybe it'll never happen. So this way you could force them to pace. And so the magnet forces pacing. For an ICD, all the magnet does is suspends the sensing, if you will, and therefore it won't fire. Okay, so what it does is, now it used to be back in the day also you could power them down, it would go beep, 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 some devices, and everyone, especially, we have 2 anesthesiologists in the room, they would bug out about patients going to the OR, and they would make the pacer rep come in and interrogate them because the machines were kind of difficult back then. But now it's pretty straightforward. If you take that wide elastic tape stuff and you park a magnet, it's going to be fine. The Bovie's not going to mess with it. And then you have a problem in the OR, you just take this thing off and it's going to work. And that's sort of the lines that the protocol is in Maryland, that if it's functioning abnormally, which sometimes it does, then you can suppress it, but then if you need it, you just undo it. And so the magnet stops defibrillation, but it force paces, but every ICD has a pacemaker, which is usually set at a very low rate, so that way, if you shock the person into asystole, it paces them up for you. It's usually, when they have an ICD with a pacer, the pacer, nothing happens to that pacer when you put a magnet on it. Okay, it only suppresses the ICD part. Any other hot topics? Okay, thank you again.